But I'm very, very honored to introduce Dr. Ravi Mehta. He will be speaking on optimizing fluid removal on renal replacement therapy.
Thank you, Ashita and Ian. I think following up on Dina's presentation, one of the key issues comes up is how do you manage fluid in patients who are on dialysis for AKI. And this simplistic cartoon is probably very evident to all of you. Is essentially the only way we access the vascular space is through the dialyzer, but we are not accessing the rest of the fluid, and we are dependent upon obviously movement from the extravascular space into the intravascular space to access and remove the fluid. So, if for most dialysis machines we have now, obviously the limits imposed on how much fluid you removed are machine dependent. In intermittent dialysis, generally 2 liters an hour is the upper end that you can remove, whereas in CRRT, you can remove it at a much higher level. But needless to say, there are 3 possible solutions that you could have for fluid removal then. The first might be that you enhance the ultrafiltration rate to try and remove fluid. Because if you've got somebody who is very edematous, that would be an option for going for it. I'll just show you some data from the chronic population because we don't have as much equivalent data from the acute side. But this is a study which was done from a DaVita dialysis units where they took a cluster sample of about 218 hemodialysis patients, and they measured the systolic blood pressures. This is almost about 20,000 readings during a clinical protocol, and they assessed the predictors. And you can see here is the pre to post dialysis blood pressure change is about 11 millimeters of mercury. The ultrafiltration volume is about 2.8, and as a proportion to the total body water, and you can see the total body water as a rate in mLs per hour. So about 725 mLs per hour, which means in about 4 hours you would be removing about 3 liters of fluid. But what that translates into is when you look at the consequences of this here's the quartiles of ultrafiltration rate. Is the higher the ultrafiltration rates in each of these patient groups, the higher the chances of adverse outcomes. So this is an absolute systolic blood pressure spline, but you have worsening outcomes related to this. In another very revealing study comparing European practices to US dialysis practices, you can see here is 3 sequential hemodialysis in a week. If you look at the sequence in these patients here's the total ultrafiltration volume, the rate about 9, 8, and about 8 mLs per minute per hour per kilogram per hour in the Dutch dialysis patients here, and look at the incidence of dialysis hypotension is about 7%. And you compare that to the US practices where you've got the decline is significantly higher, 50%, and a hypotension rate is almost twice as much, but related to the fact that they have UF rates which are much higher in this setting. So that ends up being, and when you look at the DOP study, which is looking at the dialysis patterns across both the US and Europe, you can see along with this, when you look at an ultrafiltration rate of 10 mLs per kilogram per hour versus the treatment time, the longer the treatment time lowers your mortality risk, the faster the ultrafiltration rate makes your mortality risk go up. And that is associated with cardiopulmonary mortality to a large extent. Now, why is that the case? So this, I'm indebted to this from Nick Selby and from Chris McIntyre's group and Dr. Huda Mahmood to give you this finding. So this is a four ventricle view of a cardiac echo, and you can see that you've got the right atrium, right ventricle, left and left atrium, and it seems to be beating fairly well. When I go to the next slide here, they have been measuring myocardial stunning and strain during a regular hemodialysis session. So this is, you can see here is all the segments contract and relax together, whereas in this, you can see that these segments here are not contracting and relaxing together, equivalent to what myocardial stunning may be. So they feel that this may be one of the things which occurs along with this, and what they've shown in previous studies is that this myocardial stunning is related to the rate at which you remove ultrafiltration over any session. And you can see here is that your ultrafiltration volume of 1 liter, 1.5 liters, 2 liters increases the odds ratio of stunning by almost 26 times. So if this is the case, you can also see this is also associated with hypotensive episodes occurring in the same dialysis setting. And then this last study here looking at the absolute rate. This was a prospective. This is from the McIntyre's data showing is the impact of myocardial stunning on 1-year mortality. These patients are much more likely to die in this setting. And then this additional study looking at a 5-year prospective observational multicenter study showed that when you go exceed an ultrafiltration rate of about 13 or 12.37 mLs per kilogram per hour, you have a marked increase in risk for mortality. Okay, so what does this mean? This means that the rate of intravascular volume contraction that you can take off where coronary hypoperfusion, myocardial stunning, and vascular risk escalates is observed at about 10 mLs per kilogram per hour. So if that sort of gives you a threshold, and obviously as you get to 13, you're going to have much more. So you start seeing a limit in terms of how hard you can pull this fluid off. Well, so the second part of this might be how could we improve the sequestration of fluid which is sequestered and mobilize it so that we don't have to pull that hard. So that means that we have to think about increasing refill rates. So if there's a way to increase the refill rate, we will need to know that the effective fluid removal will then depend upon maintaining balance between these two elements itself. So if you were to increase that, well, one way people have looked at this is looking at the blood volume hematocrit monitoring, and that gives you an idea what the blood volume is doing at the time of dialysis. And you can see that these patterns reflect here is that as you start increasing fluid removal, you concentrate the blood, and that reciprocally reflects the blood volume change. And you can see that if this rate of change of blood volume is very fast and your refill rate doesn't catch up with it, you're more likely to have hypotension in that setting overall. So as a consequence, if you look at a traditional dialysis program and at the end of a dialysis session, you will see this refill occurs into the blood volume. The faster you remove, the more this refill is going to be, and the more that correlates with overall myocardial stunning, hypoperfusion. And what has been shown, we've shown this in the past looking at a combination of bioimpedance and also crit line monitoring, is that your maximum, the way of plasma refill in most people is about 5 mLs per kilogram per hour. So when you've got this imbalance of 5 mLs per kilogram per hour of refill rate, and you're trying to pull off at 10 mLs per kilogram per hour, you're going to periodically have much more episodes of hypotension. So that sets you up right at that setting there. And we recognize that part of the refill is being determined by how much albumin and oncotic pressure is in the vasculature to pull the fluid back from the interstitial compartment overall. But we also know that from now, we used to believe that this endothelial cell barrier was simply the cells lining each other. We now know that there's this endothelial glycocalyx, which is partly like a little carpet. This carpet stays on top of the endothelial aspect. It is made of proteoglycans and silicon sulfate. And as a consequence, when you have disruption in this carpet for whatever reason, that sets into motion a lot of the leukocyte adhesion molecules. They get exposed, you get everything else, and you get leaky membranes overall. And as you can see here is ischemia reperfusion injury concentrates and does the same thing on the vascular lumen as such. And we know that the compounds that you use to replenish in terms of fluids, and amongst them, if you see colloid fluid solution, this is a guinea pig model where you've got a guinea pig heart with coronary flow. And if you resuscitate this model with a colloid-free starch or albumin, notice that albumin gives you the best chance for making this barrier intact and giving you the best opportunity to maintaining it. So there is some opportunity here for us to be utilizing this. And what is felt is that since these molecules are negatively charged, they attract positively charged molecules. So that positive charge is now exposed, so the albumin in the plasma space can bind to it, creating like a double layer to replenish what has been lost. That's an assumption. We don't know that actually happens. But what that implies is then, is there a way that we could harness this in a particular way? And people have been studying this with terms of sublingual microcirculation aspects. We have a device, we have the same device here. This is the cytokine part. You stick it under the tongue, and what you can get is you can get a reading like this is a normal person, this is a sepsis no flow, so you can actually capture the capillaries, you can see visually what is happening, and then you can translate this in terms of looking at what is the small microvessels, the medium sized and large microvessels. So this happens to be in patients with dialysis, a study which has been published itself. And what has been shown is that when you look at these parameters with software, you can actually determine the size of the glycocalyx. Now this is still to be proven, but at least this one particular study suggested it. So we have a technique now to potentially see what would be the glycocalyx matrix there. And what these people found was essentially that in dialysis patients, the glycocalyx layer was deranged in that setting. So if that's the case, then we have the opportunity here to optimize elements. And this is a cartoon from John Prowl showing you that if we were to be able to remove fluid and replenish this glycocalyx, well, we may have the opportunity then to make people not hypotensive in this situation. So the targeting ultrafiltration to match this and increase the refill rate while you take the fluid off then becomes something we would be interested in doing. So we know that this is possible because this study was published several years ago in critically ill patients, that if you give albumin to hypoalbuminic patients and give a diuretic, you get a much better response. We tend to use that in practice itself. So we thought, well, if that's the case, we went for an investigator-initiated grant, which Grifols funded for us, and we asked these three questions. Could the utilization of IV albumin enhance the efficacy of fluid removal in hypoalbuminic patients? And can this improve the safety of fluid removal? And then does utilization improve microcirculation in these patients itself? Now, what I'm going to show you is just the initial few patients on this. We have not completed this. This is an ongoing study itself, but these are hospitalized adult patients who have AKI and AKI on CKD, who require fluid removal, and their albumin level is less than 3 grams per deci per liter at the time of dialysis initiation. These are the exclusion criteria, and it's a crossover design where patients are randomized to either start with getting albumin, 25%, 100 ml, so 25 grams of albumin, or 100 mLs of normal saline at the start of dialysis. And then we are tracking their dialysis run session overall, and we are looking and seeing what is the blood volume monitoring, bioimpedance, sublingual microcirculation, cardiac echoes. Unfortunately, when we started this study, Fresenius, which has the blood volume monitoring device, took it off because they had some problems with it, so we've not been able to do blood volume monitoring these patients, and we've not got bioimpedance data as yet, but we do have the rest of these in the few patients itself. So far, very small numbers, but just to give you an idea of what it looks like, here is sort of the demographics in this setting here. Nothing's dramatically different from what you wouldn't expect for somebody with AKI and AKI-CKD in a hospitalized population. So I've got data of about 31 sessions here, and about 17 of these sessions had hypotension, 8 in each, no different. So none of the data I'm going to show you is statistically significant at this point in time, but it just gives you an idea how this might be. When you look at the number of episodes by hypotension by session, no difference across the two. What you do see is that the minimal MAP that is available during the session, which is achieved or applied in the session, at least the median seemed to be slightly different between albumin and saline, but not statistically significant. Again, for the numbers, the total duration of episodes of hypotension across the session, saline and albumin, seems to be not different itself. And the time to first hypotensive episode seems to be somewhat longer in terms of the interquartile ranges for albumin than for saline. But what is more important here is in terms of albumin and saline, these are sort of the overall hypotension and presence of symptoms. And what you find is that there were more sessions where in the saline group where you had to decrease the ultrafiltration or stop the treatment in that setting itself. And then when you look at the weight difference between pre and post dialysis, you actually are able to remove more fluid with the albumin session itself. And the amount of delivered UF as a proportion is more prominent here. Notice here in the albumin groups, you're able to take more fluid off overall than in the saline group itself. And then the proportion of times that you meet your prescribed goal is higher in the group which was given albumin. Very preliminary studies on this part. But when you look at the regional wall motion abnormalities, and this particular patient did not have any of these. But if you notice here, in this patient, these areas, and these are again, I'm indebted to Dr. Huda Mahmood and Nick Selby, these are the areas where there seems to be regional wall motion abnormalities itself. When we look at the microcirculation in these patients, this is a normal saline session before and after. It's going to take a minute to, just a second to load up, to brief there. We don't see too much difference across the microcirculation right now, but I think this needs to be analyzed further as we go through this part. So what I would like to summarize and show you from here is I think that when we look at fluid removal from RRT in these patients, we've got to keep in mind these competing interests. You want to take the fluid off, but you also want to enhance the plasma refill rate. We believe that you may be able to do that with albumin. I've still got to prove it to you over time. But essentially, I think this may be one of the areas we have to think about. Now, is there a mechanistic effect on the glycocalyx or some improvement? I don't have any idea on that as yet. I hope to be able to demonstrate that as we go in the future. I'd like to acknowledge multiple people who are behind this part, particularly our acute dialysis program nurses who have been absolutely phenomenal in supporting me not only on this, on everything else, and the rest of the team, and also obviously to Grifols for providing us the grant support. Thank you for your attention.
Thank you for a very interesting talk. Do we probably have time for one question?
I answered it too.
I see someone right here.
Dan Negoiano from the University of Pennsylvania. You mentioned the endothelial glycocalyx, and of course one of the issues about the glycocalyx is that there's a vision now that intravascular colloid really is dependent on that layer for its function. So my question for you is really what's your hypothesis? Is your hypothesis that only patients with a more intact glycocalyx are going to respond to the albumin, because that's what some people who are glycocalyx researchers sort of advocate, that you need the glycocalyx for things like albumin to work? Or are you thinking that somehow the albumin is going to restore that glycocalyx layer?
When I started this, my general hypothesis was simply in hypoalbuminic patients, if I raise the albumin transiently, I will have more push, be able to pull more fluids from the interstitial compartment. It had nothing to do with respect to whether it restores the glycocalyx or not, whether or not the permeability factor is there or not. That's simply the fundamental basic premise that I'm operating under. If it turns out that it also helps replenish the glycocalyx in some way or form, that would be something we'd have to prove, but I have no way of demonstrating that at the moment.
Okay, great. Thank you very much, Ravi. We should give you an applause, of course.